glad to have everyone join us for this International VMR today. Thanks for joining in on a Saturday and spending the weekend with us. So we'll be looking for a case presenter and 2 discussants, especially people whose first language is not English. This is a safe space for all of us to learn together. So we want to give everyone the opportunity to try and discuss. And it's completely okay if you're not comfortable saying some things in English. We're all here to help you. We have people, so many people from so many different countries and languages, and it's really great to learn about everyone's culture and language and foster this medical community together. So we're so excited that you're all here on Saturday, and don't make Robbie sad and have all of us wait for a case discussant and presenter. We want everyone to jump in. And now I'll pass on the introduction. So we can, Gabby, do you want to introduce yourself?
Hi, thank you, Gerlie, and congratulations on your match. And also to everybody who has matched yesterday. I'm Gabby, I'm from Brazil. I just finished my neurology residency here. And hopefully I will be part of the next match of neurology as well. So Sukriti, do you want to go?
Hey everyone, I'm Sukriti and I'm calling from India. It's 9:30 here. Ever since the US changed the daylight savings, and for everyone who speaks Hindi here, so glad you could join. And I'm just trying to find the word for excited, but I think I'm very nervous, so I'm going to pass on the mic to Rabia to help me out.
That's very, very kind. Hello, everyone. It's the morning here in San Francisco. It's about 9 a.m. And my name is Robbie. I'm one of the clinical problem solvers. And I was going to actually show you a Lebanese dish that my sister's mother-in-law prepared. It's called knefe. And it's like this really sweet rice pudding based dish. And I was going to show it to you, but here's the problem. It's gone, over. I finished it well before I could actually share it with you all. So my apologies. It tells you how good it was. We're really, I think Saturdays is one of my favorite days, quite honestly, because it's a Saturday, but also because we get to do this. So if you have a case, please volunteer to present it. We'd love to highlight the medical dimension of it, but also the global nature of our gathering today. And while we wait for somebody to present, you all may remember the one and only Mathieu had a fantastic, very intriguing case last Saturday where we learned about a young man who had a yet to be resolved syndrome. And if it's okay, I don't know if Mathieu has any updates for us before we jump in.
Yeah, I looked it up this morning.
Yeah.
He's been discharged a few days ago, and I feel like we haven't got to the bottom of things yet.
Yeah.
Well, the anemia has been explained by a new diagnosis of thalassemia, and as well as ulcerative colitis.
Ah, wow. And do you know how?
Sorry, go ahead.
Do you know how the journey to ulcerative colitis was made? Do you know that path or?
Well, the lab test suggested a component of iron deficiency anemia.
Yes.
So he got scoped, he got a coloscopy as well as an EGD. Understood. And the coloscopy showed Mayo 1 ulcerative colitis.
Amazing. Wow. Yeah, I mean,
so there's probably component of inflammatory anemia in the context of this COVID infection. So he probably had triple causes for his anemia. And there was this ECG changes as well. He's still pending a TTE.
Yeah, I see the echo still pending. Yes, I remember Sukriti had the unfortunate, but also probably growth-oriented task of interpreting a very tricky EKG, of which the answer is still unknown. So I will never ever forget that. All right. Well, it looks like Tiago has a case, which will be amazing. Whenever Tiago has a case, we're all on our toes. And the way we'll do it this time is similar to what we did last time, where we might actually just hang out with the clinical problem solvers crew that you just met, but also really highlight the voices from the chat. So please think alongside us in the chat, and we'll try to have you unmute yourself and share your thinking in real time, along with the thinking of the team you just heard. So please, Tiago, why don't you unmute yourself? I feel like it's almost silly to ask you to introduce yourself, but I don't know, formalities are formalities, I suppose. So please do that, and then we can jump right into the case.
So I'm a physician in Brazil. I was graduated in 2011, and I'm an endocrinologist. So I'm trying to catch up my internal medicine skills here. So I like very much being here because it's an opportunity to feel a physician again, which I like very much. And I'll improvise a case here because I see no one else has a case, but I incentivize others to present. And if there is no other case, then I'll try my best.
Amazing. Thank you so much, Tiago. I wonder if this is a good time to share the project that you are working on that has a similar semblance.
Oh, yeah. So I work in different projects, but I would say that the most special project I'm involved right now is with Gabi and Rafael Medina and Marcela. They are all here. Dhruv is also always there with us. And we are trying to replicate what you did here with Sipsovers in Brazil. So now we have 200 subscribers. Just 3 weeks we are running the project.
Woo!
We have many subscribers. It's going very well. People are enjoying it. And we are trying to, as I said, just to replicate what you did. I'm trying to, because, you know, clinical reasoning is not something that we have here. I wouldn't say it's our best. We need to improve it. So I'm trying to take with me professors from Brazil to discuss case with medical students. And we did a poll actually, and over 95% of attendees, they said they enjoy it and they would come back, and they are coming back.
That's fantastic. And for those of you listening that who won't see the chat, the Twitter handle is ELABROE MEDICINA. ELABORE Medicina, MEDICINA. Tiago, it looks like your call to action worked, and Marcela has volunteered to present a case. So I feel like next time I'm just going to be like, hi, good morning, everyone. Tiago, please incentivize folks to get a case, and it works like a charm. So thank you, Tiago, for your magic, and I'm glad we got to throw in a plug there. So Marcela, please unmute yourself, and then I'm excited to hear Tiago's thinking in the chat along, which I'm sure we'll hear from him again as we did last time. So please unmute yourself, Marcela. Tell us more about yourself, and then please take it away.
Hello, everyone. So first, congratulations on the match to everyone. Really, really exciting. And so I am Marcela. I'm a medical student from Brazil. I am in my last year. So I'm going to start.
Amazing.
Okay. It's a 40-year-old male, and the chief concern is weight loss.
Weight loss. Fantastic. I think it's a good place to stop right there, quite honestly. And maybe because Gabby is working on the teaching points, I'll ask you, when you heard this, as soon as you heard it, Gabby, what started to throw through your mind?
Sorry, you said Gabby?
Yes.
Okay. Weight loss. So I think the most important thing that I learned from Aaron, from our neurology sessions, in neurology, as I'm a neurologist, it's impossible to think about many other cases, but I will try to focus on some neurological causes here. So we have to think about the time course. That is very important to a lot of disease, of course, but especially important for neurological diseases. And it's going to be very important if these weight losses, for example, it's occurring for 10 years or 1 year or 1 month, because this is going to guide us through the possible differential diagnosis. And I think this is something that I'm most curious right now to know, also the amount of the weight that was lost.
Brilliant. More. Do you, in your experience, do some neurological diseases show up like this? If you had to list 2 or 3 things where a neurological disease shows up as a systemic weight loss, what would come to your mind?
I think the most important would be amyotrophic lateral sclerosis that can come to with weight loss, because most people have dysphagia, and also they have muscle waste that also causes weight loss. And the other ones are the paraneoplastic syndromes that can have a lot of neurological symptoms, since encephalitis, cerebellar signs, or neuropathy, some things like that. So these are the most important, I think, that I can think right now.
Yeah, I love it. Thank you. That's very helpful. I think Renato in the chat made a really, really important point. So Renato, do you want to unmute yourself and tell us more about your reflection in the chat?
I'm sorry, you meant me, right?
Yes, please. Yeah.
Okay,
Can you tell us more about your medical reflections? Tell us more about yourself. Tell us where you're from, what you enjoy doing.
Okay, I'm a medical student in Peru. I'm in my second to last year, and well, apart from medicine, I guess I enjoy music. I play guitar, pretty much that. About the I guess medical reflection, weight loss, I think, can be attributed to well, a lot of things, but the first things that came to my mind were malignancy or maybe an infectious disease, and that makes me think, you know, if we take a person from Peru, right, the first thing we think about is tuberculosis, especially in a person 40 years old that isn't you know, too old to start thinking maybe malignancy. So that made me think it's important to consider where the patient is from.
Brilliant. I love it. I think that, you know, the epidemiology has profound implications for infectious risk. And I think that's going to be key, really, really key here. And you can see Kushal is already zeroing in on that fact by asking if the patient is from Brazil. I will just highlight for those of you who are kind of listening that Thiago and Matthew both gave us a lot of information about how much weight is required. So most people use it greater than 5% in 6 months. And we learned that you can diurese up to 4 kilograms in 24 hours in patients who are volume overloaded, to give you a sense of that. And you know, one thing that Gabrielle was highlighting earlier about intentional versus unintentional. So Gabrielle, do you want to unmute yourself and tell us why you think that's important and how you might go about doing that?
Yes, sure. Hi, everyone. My name is Gabriel. I'm from Peru. And I think it's very important to start that question because some people intentionally want to lose weight. And we could like thinking other causes, but the patient wanted to do that. And in case of an intentional weight loss, I will think about dentition, dysphagia, depression, also malignancy, infection, and endocrine causes, drugs. It's also very important to look for.
Oh, brilliant. Absolutely brilliant. I think your entire your thoughts are really captured on the schema, which is the first time that that we entertained the possibility of weight loss. The key question is it verified? Scales are notoriously unreliable between people and between places. And so is it really real weight loss? And the next question is it pathologic or not? And how do we do this? We do this really by intuition. Whenever somebody's lost weight and you're inclined to give them a high five and celebrate with them that they're healthier as a result of that weight loss, it's probably not pathologic. But if that weight loss is being accompanied by anything that suggests poor health, anything, more fatigue, not feeling right, then it's probably pathologic. And the next key question is to see, is this inflammatory or non-inflammatory weight loss? Would non-inflammatory weight loss simply as a result of not eating enough, not absorbing enough, long-standing end organ diseases that are non-inflammatory, where you start to have a lot of muscle wasting, as Gabby alluded to, some endocrine diseases which have sometimes some inflammatory features, but not always, and then certain medications that can do it. And if there's inflammation going on, the odds are that you're going to deal with the trifecta of cancer, autoimmune, and infection. And in the United States, it is in that order. A lot of infection, there's less and less long-standing infections and less granulomatous infections in the US, but in different parts of the world, I bet that infection would be at the top. And the chat is alluding to the prevalence of tuberculosis. But here's a really important point. Most people here with inflammatory causes also have a component of non-inflammatory disease. What do I mean by that? Most people, when they have cachexia from malignancy, are not eating enough. So this is the role for somebody, an expert in nutrition, is at play wherever you are, here or here. And even if you say, oh, this patient's losing weight from pancreatic cancer, odds are you can do something about improving the taste of the food or access to the food or something here. So I think to summarize, we learned a lot from the chat about where the patient is. It matters profoundly, and Renato emphasized that point. Gabrielle taught us the importance of first asking, is this pathologic or non-pathologic weight loss? And a lot of people in the chat were giving us the sense of what numbers to use for weight loss. And the real key question is there inflammation going on or not? And hopefully Marcela will give us a little bit more information to go down the schema.
Okay, so since 1 year ago, he started losing weight. It was like 15 kilograms during this period. He used it to weigh around 80. 3 months ago, he evaluated with disseminated papules in his skin, especially in his legs, that was itching a lot. And some months ago, he noticed low-grade vespertine fever some days during the week. He also refers chest pain, especially when he breathes, and he has coughs and dyspnea during activities. And he decided to go to the doctor to do some exams because he was not feeling well, and he was diagnosed with hypothyroidism. He started to take the medication, but his symptoms were even worse in the past days. So he started to feeling more fatigue, generalized weakness, and he was not able to eat because he started feeling pain from swallowing. So he decided to go to the ER.
Wow, what an intriguing set of data. I mean, this weight loss now has a context. And I think the one thing that we would love Tiago's input on is, Tiago, what do you think about the diagnosis of hypothyroidism in a patient who's losing weight? And then what about the no improvement? Can you teach us more about that?
So I don't know if I can teach, but there is something that comes to my mind when I see this setting. So adrenal insufficiency. And why do I say that? Because once you have a patient with hypothyroidism, the risk of having adrenal insufficiency is higher than in the general population, because most common cause of hypothyroidism is Hashimoto's disease, autoimmune disease, over 95%. And adrenal insufficiency, the most common cause worldwide, is autoimmune as well. Hashimoto's disease is the most common autoimmune disease in the world. So most people who have hypothyroidism, they will not have adrenal insufficiency. But there is an interesting feature. If a person has both disease, hypothyroidism and adrenal insufficiency, once you treat hypothyroidism, then the person gets worse. So if they have both, you have to treat adrenal insufficiency first, because once you have more thyroid hormone, then you need cortisol. And if you don't have cortisol, then you can have a crisis, then you can get worse. So it's a very specific diagnosis I'm talking about. I'm not saying it's adrenal insufficiency, but once you treat someone for hypothyroidism and the person gets worsened and there is weight loss, you have to think about adrenal insufficiency. That's my consideration.
That's such an incredible pearl. Thank you so much. Can you see in this situation how hypothyroidism might be misdiagnosed? Is there a path to that in your mind?
Yeah, sure. There are many times people carry this diagnosis, hypothyroidism, and they don't have it. I see it a lot, and it's very common because in the past, just having a elevated TSH and people were treating hypothyroidism, and unfortunately, many physicians, they do it nowadays as well. So TSH varies a lot, and you should not treat a person just because she or he has an elevated TSH. So there is a possibility that other factors are influencing TSH, and it's just high, not because of a thyroid disease, and then you think it is thyroid disease. So the most common alteration, not the most common, but the most known alteration of TSH is sickle thyroid syndrome, but that's not the case, because in sickle thyroid syndrome, you have a low TSH, not a high TSH. but many things can play a role in TSH. So there is a possibility it's not hypothyroidism, and you have to think about it every time you see a person with hypothyroidism. I always ask the dosing of levothyroxine, because if the dose of levothyroxine is 25, probably it's not hypothyroidism. And also the value of TSH, and if it was repeated, because if you have a TSH higher than 20 and after 3 months it's higher of 20 again, then probably it's hypothyroidism. But there is a possibility it's not hypothyroidism for sure.
Amazing. That's so helpful. And I'll let that stand. I think it's so educational. And then Kushal is making some great points about TB in India, about checking for HIV, and the thoughts of the papules. Kushal, do you want to just share those out loud?
Yeah, so I was talking about my experience in India regarding seeing a TB patient. We used to have this like big TB wards, which are open wards when the beds are back to back, and all the patients are basically unmasked. The doctors seeing them are unmasked. And when I moved to USA and I started seeing TB patients, they are in like negative pressure room, and we are very N95, taking so much precautions, and it's a mandatory reportable disease. So it was like, kind of like a shock to me when I saw the difference in the way we treated TB patients here versus there.
That's super informative, and I'll tell you that it's incredible how big the world is and how different people do the same thing, medicine. It's absolutely eye-opening. Can you share with us how the thought of HIV crossed your mind, just to teach everybody?
Yeah, it's looks like patient has chronic inflammation, and whenever I see chronic inflammation and disseminated papules in the skin, the first thing that comes to my mind is it molluscum, like umbilicated papules, which is commonly seen in HIV, or the molluscum mimic, which is a cutaneous cryptococcal disease, which is also other thought that came to my mind.
Amazing. So we're thinking, hey, papules disseminated in the context of a systemic syndrome. Think HIV with molluscum or cryptococcal with mets to the skin. And on that point, Gabriel has another infection he wants to throw in the mix. What is that, Gabriel?
I said about post-Calazar anise manifested after treatment of visceral leishmaniasis. And visceral leishmaniasis is here in America is presented in Brazil and Mexico, not here common in Peru. In Peru is more common cutaneous leishmaniasis. But yeah, just my ID lover brain speaking right now.
100%. That's super helpful. I'll summarize all this in a second, but I just saw that Valeria had a great point about a patient she saw earlier who had anorexia, and I think that was very educational. Do you want to share that out loud?
Hello, everyone. Yes, actually, just it was a comment because people were saying, is it intentional or not intentional? And Drew mentioned that some patients can have intentional weight loss. Like we were expecting this patient I saw when I was doing my psychiatry rotation a couple years ago, that had a hypothyroidism. So we were expecting, because of her medication, that she will lose weight. But she also had a diagnosis of anorexia, and so she was abusing her medication, and so both things can coexist.
Geez, that'll burn in my mind. Thank you so much for sharing that. We've talked about the hypothyroidism, we've talked about the papules, and I will love for Gerline to unmute herself and tell us what she's thinking about the chest pain and essentially the pleuritic chest pain in this case.
Yeah, so I think the overall picture I'm getting is that there's some type of systemic inflammation given the weight loss and the generalized weakness. So the more localizing feature is the chest pain that's specifically pleuritic or worst with breathing. So when I'm thinking about pleuritic chest pain, I'm thinking about kind of anatomically what could be causing it. So is it something in the chest wall, like the pleura, or muscle or nerves or other portions of that area that's being irritated? Or is it something in the mediastinum, like pericarditis, or some more inflammatory process that's due to an underlying infection or something like that. And also, usually we think about the chest, the pleuritic chest pain as being all the organs in the chest, but you can also get it with things such as like irritation of like the liver or the spleen. So thinking about some of those extra thoracic organs as well when approaching pleuritic chest pain.
That's absolutely brilliant, Gerling. I think that your teaching really emphasizes, so I have to have my video off for a second. I'm trying to do something with my puppy here. But if you think about pleuritic chest pain, it fundamentally means that that there's pain only when the patient takes a deep breath in. So what is it about that breath that causes the pain? And that's when you just have to close your eyes and imagine what the lungs make contact with as you breathe. And they make contact with the pleura and the chest wall. They make contact with the mediastinum, and they make contact with the diaphragm. That's the three-dimensional movement of the chest, forwards into the chest wall, sideways into the mediastinum, and downwards into the diaphragm. And so if you think anatomically, you're like irritation of the pleura or the chest wall, irritation of the mediastinum, or irritation of the diaphragm. And there's a CP solver schema that illustrates this more. And the most important diagnoses to entertain are pericarditis in the mediastinum, a subdiaphragmatic abscess in the diaphragm area, and then in the chest wall, pleuritis of any cause, infectious, malignant, otherwise, or something in the chest wall, like something in a bony disease that's part of this syndrome, like in the ribs, etc. So I agree with you. That's the most localizing feature. There's something that the lungs are hitting in the chest wall or the pleura, in the mediastinum or in the diaphragm that will tell us what is going on. And so I'm really, really intrigued to see what that is. But we'll summarize. We have a working diagnosis of hypothyroidism, which Tiago told us is at risk for being misdiagnosed. But if it's true, then we have to think about adrenal insufficiency in a patient who is not responding to treatment for hypothyroidism. And then we learned from 3 or 4 people at the same time that disseminated papules in the context of a systemic syndrome should really prompt analysis for HIV and the infections associated with that, ranging from viral molluscum to a bacterial, Mycobacterium tuberculosis or NTM, to fungal in the form of Cryptococcus, histoplasmosis, paracocci, and then to other parasitic, which would be visceral leishmaniasis after treatment, otherwise known as post-Kala-Azar. So a lot to play with, but I agree the center of gravity in this case for an internist is in the pleuritic chest pain. So eager to hear more about that. Back to you, Marcela.
Okay, so his medications was levothyroxine, 50 mcg. He drinks beer and other drinks, especially during weekends. He's married. He refers unprotected sexual activity with his wife. He has 2 dogs in his house and a lot of chickens. He has frequent contact with the rural environment, no recent exposure to lakes or caverns. He visited Rio de Janeiro 1 year ago, and he denies traveling to other places recently. I will go to the physical exam too, okay?
Perfect.
So the temperature was 36.8, heart rate 82, blood pressure 90/60, respiratory rate 21, oxygen saturation 93 in room air. He looked pale, no icteric, no edemas. He had enlarged in posterior and anterior cervical and axillary lymph nodes. The cardiovascular exam was normal. Pulmonary exam, the vesicular breath sounds were decreased and some diffuse bronchi. In the abdomen, some diffuse pain to palpation. He had hepatomegaly, around 3 centimeters under the right costal margin, and splenomegaly. The neurological exam was normal, and in his skin, he had erythematous papular lesions with some crusts and scoriation, especially in his legs and arms, and some in the chest. Also, in 2 days after the admission, he complained of testicular pain. So we did the exam, and he had a palpable and painful nodule in the right testicle.
Oof. Wow, super intriguing. Kushal has one of the most amazing sentences in the chat I've ever seen. It says, chicken poop equal histoplasmosis, which is just absolutely perfect. Vishal, I will spare you unmuting and repeating, but thank you. I'm a math person and I love me some equations. And when chicken poop and histoplasmosis are part of an equation, I'm just eternally happy. You literally made my day today, my friend. Thank you. Sukriti, I know you're typing away very, very fast, but I'm curious, as you take a breath, of all this exam as you were typing it, what jumped out to you?
I think the abdominal exam, given that we had the complaints of of a more respiratory nature, so the fact that this patient also has hepatomegaly and splenomegaly now will change the direction in which we'll take this case.
100%. Unexpected, right? Like the center of gravity was the chest before. Now we have a lot of abdominal findings. So I'll tell you, as the chat collects its thoughts and takes some time, I'm sorry if I missed a couple of things. Splenomegaly and lymphadenopathy seem similar. They do. But the overlap of splenomegaly and lymphadenopathy is a great filter by which you can really eliminate some causes that only cause lymphadenopathy and only cause splenomegaly. So let's do that exercise together. Okay, I'm going to share the screen with you. So, here we are. Of the cancers, remember that solid cancers can metastasize to the lymph nodes. We use lymphadenopathy as part of the staging of solid tumors, but solid tumors don't go to the spleen. So if we're thinking cancers, we're limited now in the combination of lymphadenopathy and splenomegaly to only liquid tumors. So to summarize, when you see lymphadenopathy and splenomegaly and you're studying the possibility of cancer, the possibility of solid tumors just went down. Let's study infections. Mononucleosis refers to things like HIV, EBV, CMV, which can cause an acute mono-like syndrome. Granulomatous infections refers to any infection that can hide in a macrophage, and there are about 20 or 30 of them. Both of those have the propensity to cause lymphadenopathy and splenomegaly. Syphilis goes to lymph nodes but doesn't go to the spleen. Tick-borne diseases go to the spleen but don't go to lymph nodes. Hemolytic diseases like Babesia and malaria go to the spleen but they don't go to the lymph nodes. So if you're thinking about infections, you're probably in mono and granulomatous infections. And mononucleosis syndromes don't present as subacutely as this patient does. They just don't. They don't take this long. They can in immunocompromised patients. So if this patient turns out to be immunocompromised, we can think about this. But now I think I would cross this off, mononucleosis, because of the possibility, because of the time course here. So we're already on liquid tumors and granulomatous disease. There's no drug here that's culpable. We haven't heard of any drugs that can cause drug-induced hypersensitivity syndrome. And you'll see the autoimmune diseases is also reduced by the combination of lymphadenopathy and splenomegaly to really the 3 S's. Sarcoidosis, lupus, and Stills. Autoimmune and drug are below because they're much less common. Really, the focus is this a lymphoma or this is a granulomatous infection? And the list of granulomatous infections is very, very, very long. But I think how do you begin to make progress how do you begin to make progress by granulomatous infections? I think we start where we start where everyone else has already reflected on, which is study the syndrome. And Kushal gave us a list of infections to study papules, most of which are granulomatous except molluscum. And I think we can reduce molluscum now because there is visceral manifestations that molluscum wouldn't do. So maybe what I can do is we've zeroed in on lymphoma, leukemia, or a granulomatous infection, and I'll ask the chat, just make a list of granulomatous infections, and maybe we'll ask a few people to share an example of granulomatous infections and highlight an illness script about them. So I'll just scroll up because I think a couple were mentioned. So why don't you name your granulomatous infection and go from there. And I see Nilan has mentioned psittacosis. Do you mind to unmute yourself and teach us about psittacosis?
Hi, Ravi.
Hi.
Yeah, so I'm not very sure, but I think when I hear about birds, so as Kushal said, histoplasmosis equals chicken poop. But when I hear about birds, psittacosis is the first thing that strikes me. Yeah. And I mean, it affects, I think it affects lung, but it's more of an interstitial pattern. So I'm not really sure if it counts here.
I'm not sure either. I think when you hear bird, you have to think Cryptococcus, psittacosis, and histoplasmosis. I have to tell you, I'm very weak with psittacosis. I probably would miss it. Could it do it? If I had to guess, I'd say you're right. I think it could do it, but I actually don't think I know enough about it to be very, very confident. So while you were talking, I just made a bookmark to read more about psittacosis, unless somebody else here knows in the chat. Okay, I'm, you know, and Drew, do you want to emphasize your point about the social history, please? I think it's a really, really important one.
Sure. So, well, a couple of things. One, just going to reiterate the point that when you had said that lymphoma and leukemia are far more likely over solid tumors, I think you had mentioned before, and sort of as a memory hook, that solid tumors are allergic to the spleen. So, just a way to sort of remember that.
Absolutely. Thank you for remembering it.
Lymphadenopathy.
Makes me blush when people remember things I have to say. Something's working.
Yeah. So in terms of the social history, and I mentioned this because it'll probably broaden our differential. This patient has had unprotected sexual activity with his wife, and we seem to have at least an incomplete sexual history, and because it's unprotected, that increases the risk that this patient may have HIV. And if the patient has HIV and they're immunocompromised, our list of granulomatous infections that we have to consider becomes ever larger. And the other thing is that this patient also has a palpable painful nodule on the right testicle. So sexually transmitted infections may also be on the differential as well.
I love that. I apologize for having to, I'm actually on service and just got a, not the super urgent text, but something I had to respond to. And I completely agree with you. I think that, you know, it does expand our differential diagnosis for sure. And I think that expands the spotlight. And I think that's going to be the key question is the patient HIV positive or negative? And, you know, as we start to take inventory of what organs are involved, we know the chest is involved. We know the abdomen and the liver, spleen, and lymph nodes are involved, and the testicle is involved. And I'm going back to Tiago's point with that soft blood pressure. Are the adrenal glands involved? Because we have to try to find the organ involvement that is most restrictive in its differential diagnosis. Believe it or not, testicular pain here, the testicular mass doesn't really limit the differential diagnosis much. If we're calling it epididymal orchitis because that's the only inflammatory disease process in the chest, and we're zeroing in on infection because we're not because we have to exclude infection before we think about lymphoma. Lymphoma in the testicles does occur, but it usually occurs in older adults. In fact, testicular lymphoma is the most common testicular tumor in patients over the age of 50. So the age of the patient here and the involvement of the testicle makes that a little bit less likely, but certainly not impossible. So what infections involve the testicle in the form of epididymal orchitis? Unfortunately, if you look closely at this list, you'll see that all the granulomatous infections that we were entertaining, except leishmaniasis, involve the testicle. So here we are. We're like, well, mycobacteria, brucella, melioidosis, which is not at play necessarily, cryptococcus in the endemic mycosis. And as Drew mentioned already, the routine sexually transmitted infections are at play here. So at the end of the day, if we're really going to have to test for all these infections in some way, shape, or form because the patient is at risk of mycobacterial disease, the patient is at risk of brucellosis, the patient is at risk of not all the endemic mycoses, but most of the endemic mycoses. So how do we make progress? I would say the adrenal insufficiency, putative adrenal insufficiency, is the most restrictive because the list of infections that cause adrenal insufficiency is much lower than the list of infections that we're dealing with here. I won't share an approach for that yet because it might be wrong, but I think the diagnostic exercise here is we know the patient has either a granulomatous infection or a lymphoma. The involvement of the testicle makes lymphoma less likely because of the age of the patient. So we're really prioritizing a granulomatous infection, and we're going to need to find the organ that has the most limited number of differential diagnosis to begin. And I hope that's the adrenal. And if it's not, we're going to have to test widely and see what happens. So Marcella, I'll give the mic back to you.
Okay, so hemoglobin was 11.2, hematocrit 32.5, MCV 86.9, white blood count was 4,500, with 77% of neutrophils, 30% of lymphocytes, 9% of monocytes, 1% basophils, and 180,000 platelets. TSH was 1.42 and T4 1.21. CRP was 3.57, urea 33, creatinine 1.17, K 3.93, sodium 137, AST 40.5, ALT 33.5, GGT 162, ALP 195, total bilirubin was 0.44, and directly 0.29, indirectly 0.15. So his ferritin was 2868, LDH 294. So, and he had, in his X-ray, he had a strange image that looked like a cavitated lesion in the upper apical right lung.
Woo, getting spicier and spicier. Gerline, where are you at?
Yeah, so there's a lot of information. What I'm right now was thinking through like the labs, what jumped out to me was, I think the alk-phos and the GGT are high. So I was thinking about if this is some sort of cholestatic picture and that the alk-phos and GGT are high. So the other aspect was the ferritin was high, which kind of goes along with their picture of chronic inflammation, ferritin being high. And then the cavitary lesion is kind of, I think, the pivot point with the location in the right apical regions of the lung. So when I think about apical lung involvement, I think about reactivation of TB affecting the upper lobes. So those are my initial things from the labs and imaging.
Yeah, I'm right there with you. I think that we're there. You know, now we've basically, like we were saying, this is a granulomatous disease or a granulomatous infection. And one second, my mom is asking me a question, which seems very important. Yes. Yes, thank you. You're so cute. What was I saying? Oh yeah, we're dealing with a granulomatous disease process, and I think that the cavitary lung lesions are the pulmonary manifestation of this process, right? We talked yesterday actually about the differential diagnosis of cavitary lung lesions, where it is a granulomatous infection and some parasitic infections and a lung abscess. And here, I don't think the lung involvement is helps us make progress, unfortunately, because we're already there. The question is, what do we do with the other data? We have hepatic involvement, which again goes on to the same cholestatic manner that it has of granulomatous infection. So I think the question is, what granulomatous infection is this? And I don't think you can make much more progress. So in real life, what do? I think you have to isolate this patient and test for tuberculosis through smears. You have to send a Brucella agglutination antibody, you're probably looking for nocardia in the sputum as well. You humbly recognize that that testing for the endemic mycoses and cryptococcus is the way to go. So cryptococcal antigen, histourine antigen, and paracoxy testing, I think would be a priority. But does this patient have HIV? Will help us a lot. And does this patient have adrenal insufficiency? Will help us a lot. So for the sake of time, I think we're zeroing in on a granulomatous infection as we talked through from the overlap of lymphadenopathy and splenomegaly. Lymphoma is very probable, but unlikely because of the age and less likely to cause a cavitary lung lesion. So I'll pass the mic back to Marcella to just give us all the data that she had before the diagnosis, and we'll try to put our heads together.
Okay, so we did exactly that. The patient was isolated because of the suspicion of TB. We did a CT that was revealed mediastinal lymph node enlargement and small cavitated lesion in superior segment of the right lung. Splenomegaly with hypoattenuating images suggesting of nodules. He had an unnecessary spleen and some densification of mesenteric fat that was suggestive of inflammatory process. The head CT was normal. We did an ultrasound to see the nodule. It was a hypoechogenic area of architectural distortion with areas of hypervascularization in the right testicle. And HIV was positive. VDRR was negative. Serology for Hep B and Hep C was negative. He was IgG positive for toxo and CMV. And the cryptolatics in the blood was negative. And we did a skin scraping for the lesions. It was negative. Mainly that.
All right, y'all. I'm going to lean on the chat. Kushal is mentioning the possibility of pileosis hepatis from Bartonella, which would explain the skin findings, the splenic findings, the lymphadenopathy. I am not sure if Bartonella involves the lungs. I think that's the minus against Bartonella, but certainly a very strong match and something we should definitely test for. Anything else? Gabrielle mentioned tularemia, 100%. Tularemia is a notorious granulomatous infection, typically acquired through tick bites. So acquired through the skin, and has the typhoidal tularemia is the one we'd be thinking about now in its manifestations. Tiago is wondering, Marcella, do we have a cortisol, or was that not obtained?
No, unfortunately not.
Okay, no problem.
We were not thinking mainly about that, so.
No worries at all. I'll summarize the case so far and read off what Drew said. So this is a 40-year-old man with chronic inflammatory syndrome with pulmonary and skin manifestations, in addition to hepatosplenomegaly, lymphadenopathy, and a testicular lesion, who was found to have HIV. Okay, so where do we go from here? To Kushal's TB histo, 100%. Paracoxy. Mario, can you please unmute yourself and teach us about paracoxy, my friend? We haven't heard your voice today, and I will withdraw from it if I don't hear it every Saturday.
Okay, hi everyone. Okay, paracoccidal mycosis is endemic mycosis, usually in the South America. It can have diverse manifestations, especially there's an acute or juvenile manifestation that is more compatible with this type of picture, with disseminated generalized lymphadenopathy, hepatosplenomegaly, bone marrow infiltration, but usually and it's usually more common in children and immunocompromised people. And there's a chronic, subacute to chronic manifestation that usually presents with chronic lung lesions and other type of extrapulmonary manifestations, but it's not usually more localized infection. So it could be, especially in patients that are immunosuppressed, like this patient, can have a disseminated type picture.
Brilliant, 100%. Nothing to add. Okay, let's go systematically, my dear friends. Where? Oh, wait, hold on. I thought I opened it. 1 second. I'm slow today. Let's be systematic. Oh man, I was just about to share my text messages with you, which I wouldn't be embarrassed about at all because why not? Oh man, sorry. 1 second. I don't know. I'm not sure why it's not opening. Okay. Is it Bartonella? Maybe, but lung involvement is a little bit less likely. Is it leprosy? Probably not. Can be. Melioidosis? Probably not. Tularemia? Maybe. Probably not. Sporotrichosis? Maybe. Probably not. Leishmaniasis? Maybe. Probably not. Why? Lung involvement, disseminated disease? Very possible, really, but not prevalent in that part of the world, certainly described. Tularemia, very possible, but again, base rate would make that less likely and doesn't really go to the testes. These are too acute. Doesn't go to the testes, doesn't go to the testes as much. Oh my God, heck yeah, mycobacteria. Nocardia, not so much testicular involvement. We talked about this already. Ruled out essentially by the serum testing. Endemic mycoses, I think histo and paracoxy are very important considerations. So we're like mycobacteria, histo, paracoxy, probably not salmonella. Why not brucella? Most brucella involves the bones. So the lack of spondyle disease here is a little bit less likely. Mycobacterium bovis for sure. And Mycobacterium bovis can look just like tuberculosis. So when you're thinking Mycobacterium tuberculosis, you have to think Mycobacterium bovis. So what's our short list? I think our short list is Mycobacteria, histo, paracoxy, and Mycobacterium bovis. Anything else that you all would add to that short list? In the chat? Oh man, I'm slow. I don't think so.
I think there was a mention of, Nilian had mentioned it, of possibly thinking of an autoimmune cause like GPA.
Mm-hmm.
Like just sidestepping the whole issue of HIV. But I think we should prioritize infection in this patient considering that he has HIV and infection is probably going to be far more likely.
You know, the signature of granulomatosis polyangiitis is a very unique one. And the one notable absence is the involvement, lack of involvement of the reticuloendothelial system. So you won't see hepatosplenomegaly lymphadenopathy. That's not to say that you cannot see it, but you usually don't see it. All right, Marcel, the tension is too strong. Please take it away. Tell us what this patient had.
Okay, we did the screening for acid-fast bacilli, and it was negative. And we decided to do a bone marrow puncture and biopsy since the skin scraping was negative too. And I have an image. Can I share the screen? I think I'm not able to share.
I have to do one thing. While I do that, can you teach us what you were looking for in the skin scraping?
Yeah, we were mainly thinking about histo or paracoccidoidomycosis because it's more common here in Brazil. And we were trying to find histoplasma in the screen. So it was negative.
Okay. All right.
Okay.
The screen is yours, my dear friend. You are now a co-host, so you can hijack this meeting. You can shut it down. You can share a screen. You can do whatever you want. You're very powerful now.
So here is the bone marrow. Does anyone want to any comments on that?
I'm gonna hide now, but Kushal says histoplasmosis. Unmute yourself. Please, my dear friend, tell us why.
Yeah, I think I see the yeast in the macrophages there. Yeah. And that's why I usually, it's when I see the circular lesions, circular inclusions, I think of histoplasmosis or leishmaniasis. Leishmaniasis will have amastigotes, but I don't see it really well.
Amazing.
So I'm thinking of histoplasmosis.
Cool. You know what I did? I actually didn't look at the image at all. I'm so bad with pathology that I started to look at the title of the folder. I was hoping you would say histoplasmosis image or something like that, and that would be my guess. But I'm glad Kushal is here is much smarter than that. So Marcella, please take it home. What was this, and what did you do for the patient?
Yeah, so Kushal is right, as always. It was really histo. We started treating the patient and he improved it. But for our surprise, some days later, the lab called us and they said that the culture from the bone marrow were growing Cryptococcus neoformans. So he had both in his bone marrow. And we repeat the Cryptococcus latex because we were, oh my God, why it was negative? And it was actually 1/10 for 24. And I did the lumbar puncture because we were worried about the crypto in the CSF, and it was negative. And the patient improved his symptoms, the fever disappeared, and the testicular nodule was not painful anymore, and it was better, getting smaller.
Absolutely amazing. Thank you so much, Marcella. I cannot believe that this bone marrow grew Cryptococcus. I will tell you, this is a humble reminder of what's called the prozone effect. The prozone effect is when you have so much antigen circulating, it actually binds all the antibody you send to look for it, and you lose all your antibodies that you sent to look for that antigen. And so you think it's negative. And so sometimes you have to dilute the sample enough to be able to detect that phenomenon. It's classically described in secondary syphilis, where the RPR is so high that you would no longer find it because it steals all the antibodies you put in the solution. And I think that's probably what happened here, given how high the titer eventually was when you retested it. Absolutely fascinating case. We're a little short on time. We only have a minute left, so I will hand the mic to Gabby to summarize the teaching points. But really, really, thank you so much, Marcella. It's an incredibly educational case, and I can't tell you how incredible it is the way you presented it. It really made for a great discussion. And thank you all for folks in the chat. I really enjoy hearing all these different voices, and I think Saturdays is a nice place to step away from the two discussant model and just have everyone participate, and I hope you enjoyed it too. All right, Gabby, please take it away.
Thank you, Marcella, again for the great case. Rabbi, speaking about the Elabori Medicina, we also want to invite you to participate. You are more than welcome. Just let us know when you want to. So about this case, we had a case of a 40-year-old male that presented with weight loss. The weight loss was from 1 year ago, and he has lost a significant amount of weight. So the first thing that we discussed was the approach to weight loss, and we have to think between pathologic or not pathologic. Is the person trying to lose weight or not? Intentional and non-intentional. Inflammatory, non-inflammatory causes. Inflammatory can be decreased intake or malabsorption, and non-inflammatory can be cancer, autoimmune, or infection. Also, chronic diseases, endocrinopathy, and medications can cause weight loss, so we have to be aware of all of these possible causes. Okay, so we also talked about because this patient had a history of hypothyroidism being treated, and he got worse after starting the treatment. And when this happened, we have to think about adrenal insufficiency. Also, he presented with chronic skin lesions that looked like disseminated papules. And in this case, we have to think about molluscum, which is common in HIV patients, and also cryptococcus disease. He also had splenomegaly and lymphadenopathy. We saw a great schema about causes of both splenomegaly and lymphadenopathy. But some important causes of these two manifestations are lymphoma and leukemia. The solid tumors do not cause both of these. Infections, mono-like, which are more acute, and we didn't think about this case because he had symptoms for more than 1 year. And granulomatous disease because they are more chronic. Also, autoimmune disease that we can remember thinking about the 3 S's: sarcoidosis, systemic lupus erythematosus, and Still's. We also discussed about cavitary lesions, like we discussed yesterday, but we have to think about the granulomatous disease, parasitic infections, and also lung abscesses. And thinking about Paracoccus styriodomycosis, we had a great review today because we talked about the endemic in South America, presenting with disseminated lymphadenopathy, hepatosplenomegaly, skin manifestation, weight loss, and associated with pulmonary manifestations. We also learned that the diagnosis is kind of easy to be made because we can see the Mariner's wheel in the KOH. So I hope everyone has enjoyed the case, and thank you for participating.
Hey, Gabby, I think you're the most knowledgeable neurologist about internal medicine ever under the history of the sun with your ability to do this. It's incredible. Thank you so much for doing that. It's not easy. It's not even your specialty. You're absolutely crushing it. Thank you. You know, folks, I have a favor to ask. I can't help but recognize how many people, how much people would be enjoying this free gathering of the minds and talking in medicine. So please, 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 if you're able to, spread the word. When you tell people one-on-one and people you trust, they'll come, they'll learn, and we'll hopefully make the medical world a better place for our patients. And I've learned so much from here, and so much better in my ability to take care of my patients because of you all and because of this. So please, if you have time, just spread the word. I cannot imagine that there's not more people out there in the world who would really, really enjoy being part of this family. So think about that, and if you can, please do that, and hope to see you around any day this week, but especially next Saturday. All right, bye.